For this lecture, we're going to focus on ionizing radiation. And you can think of this lecture as being a preface for our other ionizing-based lectures. So when you think about the medical imaging subsets, with the exception of sonography and MRI, ionizing radiation is used in a very beneficial way that really enhances how medicine is practiced. So we have projection radiography, fluoroscopy, CT, nuclear medicine, cardiac catheterization, radiation therapy that do utilize ionizing radiation to enhance diagnosis, to treat patients. So a lot of good comes out of it, but also, of course, the risks that are associated with it. So throughout this lecture, we will talk about some of those benefits versus risk, and I think you really get kind of a global perspective of ionizing radiation as a whole. In terms of risk, ionizing radiation simply means that the radiation that we're using is capable of ejecting electrons inside of our patients, specifically at the atomic level. So whether we're talking about interacting with oxygen or interacting with carbon, it's interacting with our body, and it's so within those atoms, it's ejecting those electrons. So whether that's an inner shell electron or outer shell electron, it's still ejecting electrons within our body. So it's creating some form of instability, which does have the potential to damage tissues. And of course, different risks are associated with the amount of dose or how that dose is delivered. So more risk is associated with doses delivered continuously over time or one large, massive base exposure. So all forms of ionizing radiation do carry some risk, though, and simply we're talking about that stochastic nature, and we'll start to break down the differences between stochastic effects and deterministic effects, and but what we're really concerned with in every single modality is that stochastic nature. So in general, ionizing radiation does fall within the electromagnetic spectrum. So we'll revisit that spectrum. You'll kind of see where it fits in. But there are several other types of ionizing radiation as well. So X-rays, of course, are a part of that EMR spectrum, electromagnetic radiation spectrum. But gamma rays are as well. What's not associated with the electromagnetic spectrum is particulate-based radiation, which may include beta particles or alpha particles. So simply, ionizing radiation has the ability to be absorbed, scatter, or be transmitted through our patients, and we can use it in a variety of different ways. One particular symbol that you may not be aware of is this particular symbol here, a little bit terrifying to say the least, with the skull and crossbones and the man running feverishly away from the radiation source. But it is considered to be the international symbol of radiation. So this was launched in 2007 by the IAEA, and it's intended to actually not be demonstrated like on a wall like our traditional radiation symbols, but it's intended to be placed on the housing of the source, just as a warning not to dismantle the device. So typically it's not visible under normal use, but when you go to disassemble the device, it's just one of those additional things. So you're not going to see it on access doors, transportation packages, or containers. But it is a symbol that you may see at some point. So just got to keep that in mind. Now, to revisit the electromagnetic spectrum, you can see how it's organized from radio waves through gamma rays. Should tell you that you're going from a long wavelength through a short wavelength in this case. So radio waves are the longest wave, gamma rays are the shortest wavelength, and by definition, wavelength is the distance between successive peaks. So from this point here through this point, or the distance between successive valleys or troughs from this point through this point, type of thing. Now you can see that the distance is shrinking as we get into our higher energy forms of electromagnetic radiation. So you can see that relationship there. Now, wavelength and frequency, so wavelength is reported here, frequency is reported here, do have an inverse relationship. So as wavelength decreases, frequency, or how often those waves occur in a given period of time, will subsequently increase. So, and then frequency is also related to energy. So higher frequencies equal higher energy, so a direct relationship there. whereas wavelength and frequency have an inverse relationship. As wavelength increases, frequency decreases. So now you can see, organizationally speaking, ultraviolet is kind of pushing ionizing levels, but really, thinking about the true ionizers, we have the X-rays and the gamma rays down at the end, so the highest of energies. I really like this graphic because it gives you a size-based relationship. So radio waves are really huge, the size of buildings, where furthering as you go down, you get really, really small. So not only do X-rays and gamma rays interact with our patient's atoms, but themselves are the size of atoms, so very, very small. So gamma rays, they're continuously active until they disintegrate down. And then the energy of X-rays is, of course, less than that of gamma rays. So you can kind of see those relationships reflected here in terms of wavelength and in terms of frequency. Now, regardless if you undergo medical imaging procedures, you're still going to be exposed to radiation, just in the form of natural or background-based radiation. So whether that's from the space, like rays, or from the sun, or radioactive materials that may be used in the building process, so rocks or soil, geographical location could also tie into that, or whether that's gases like radon, which is actually the largest exposure we have to background-based radiation, or even radionuclides in the food that we consume and drink. Air travel is something that also needs to be considered in that background form of radiation. Like I said, geographic location is a factor, altitude is a factor. But we typically think of our exposure as being that man-made source. So from the medical side of things, medical radiation, nuclear power also does factor into that. Luminous paints could be a factor to consider in the man-made process as well. Now, what's really important to think about, though, is how our exposures have changed over time. So the NCRP report number 160 gave an exposure to the population in the United States. Kind of looks like this, and shows early 80s versus 2006. And what you should first identify is that the size of the pie is larger. So larger pie, larger exposures are taking place. And what you can see is that where change is taking place is that the medical exposures are really dramatically growing. So when you look at consumer-based exposures, 2% versus 2%. What's happening here in background, going from 83% to 50%. But what's important to note is that background radiation levels have stayed relatively stable at 3 millisieverts range. So this is still 3 millisieverts here, this is still 3 millisieverts here. So really the boom in exposure is coming from that medical-based procedures. So patients are undergoing more procedures. The amount of radiation that we may use in some modalities is going to differ. So more CT exams are taking place. So of course more patient exposure is going to happen because they're high radiation-based procedures. But when you look collectively at this, at these percentages here, you can see, how many millisieverts are we actually receiving per individual, and going from 3.6 to 6.2, while it's not double, it's approaching that. So I think this forces us to think, hey, how is the Alera concept being applied? How are exams being ordered? And is this just the result of transitions and improvement of medicine, or is there something that we need to do to lessen collective population-based exposure? So even though every person may not undergo exposures on an annual basis, per population, this would be an annual based exposure, so 6.2 millisieverts as of 2006 reports. To further break down this information, so still kind of coming from report number 160, you can see truly a breakdown of where these exposures are happening. So in terms of background, of course, the largest radiation exposure, yes, is radon. You can see those small industrial and occupational and consumer-based exposures. I'm looking here continuously at those background exposures as well over here, so space, internal, and terrestrial. And then here's the portion of the pie that we contribute to, looking at conventional radiography and fluoroscopy at 5%, interventional fluoroscopy at 7%, nuclear medicine at 12%, and CT at 24%. So the largest exposures are taking place in these three windows here. So CT, nuclear medicine, and interventional based studies. So we have to be very aware of, that patients aren't undergoing by volume, they're not undergoing the same amounts of tests. They're undergoing more tests, and more tests that they undergo, the more exposure they're going to have. So we need to think about different approaches, and really this ties into how these exams are being ordered. So at the physician based level of, are we applying the appropriateness criteria? Are we looking at patients' past medical history and saying, hey, you just had an exam done yesterday, you don't need one, you don't need another one today? So are we effectively utilizing the images, and should we have more connection points to be able to better integrate and be able to determine when these studies are actually happening? And based on statistics and seeing how these percentages are changing, I would say there's very much an increased awareness of radiation and the exposures now, largely because of social based campaigns with Image Gently and Image Wisely. But vendors being involved certainly are contributing to those efforts to create awareness as well. But I think more definitely needs to be done in regards to making sure that we're doing the best we possibly can and looking at non-ionizing based modalities as being potential alternatives. While we need to do the best we can to apply ELERA throughout every procedure and really understand the capabilities of our equipment, the public also comes with their own concerns about the effects of radiation, largely because of major events such as nuclear disasters that happened in Chernobyl or in the Fukushima disaster most recently in 2011. These types of things do generate a lot of public concern. And then the New York Times ran some articles a few years back that really highlighted some medical imaging based errors, disasters, so things that happen in CT, things that have happened in radiation therapy. And when one story is picked up by a media outlet, there's a lot of sensationalism that can take place, and that can really spread and create a large amount of misconceptions about the risk of our medical imaging based procedures. You think that there are a lot of checkpoints, there's a lot of rigor associated with accreditations and making sure all of our documentation is in place, all of our quality control is in place. But one bad error can really create a bad rap for our profession. So we need to really highlight the positive value of medical imaging procedures. And this goes back to that balancing act, is that what we do is important, it's valuable, it changes lives, it saves lives. And all of that needs to be promoted because it's important. But then we also have to think back to our previous slide and say, hey, patients' medical imaging exposures are increasing, though nonetheless they're undergoing more procedures by volume. What can we do to balance that act? So I think there's a lot to continue to think about here. And we just need to continue to think, because of the effects of radiation on the human body. We have the ability to induce any of these given effects, and with the most significant effect being direct damage to the DNA, specifically to the nucleus, because it can lead to cell death. It can lead to non-repair of certain cells, preventing them from dividing. It can lead to indirect effects through radiolysis of water that can later damage DNA. And some of these effects may be repairable by the body depending on where it's interacting and kind of the nature of the cells that it's interacting with as well. But some can't. Some are going to be very, very serious. So genetic effects can be passed on to offspring. So it's a result of damage to either sperm in a male or the ovum in a female. So not something that obviously we want to happen, but something that can happen. And then somatic effects are effects that can happen in the individual themselves. So typically tissue damage may occur when there are multiple areas that can no longer divide. We hope we don't get to the point of tissue damage within our procedures, But in terms of radiation therapy, we do damage the tissue. It's just because there's multiple areas that we're targeting, and those areas and the cells that are involved in those areas just can't divide anymore. So deterministic effects, of course, need to be minimized, but stochastic effects, when we can eliminate those cancers, those the better. We need to do that, and by eliminating how much radiation we're exposing our patients to, we can reduce some of those stochastic effects. So those effects are a little bit better spelled out here with looking at deterministic effects. So there is some type of threshold that has to take place. So meaning that depending on the area, depending on the site, will depend on the effect that's demonstrated, whether that's erythemia, so skin reddening, whether that's cataracts, changing of blood count, sterility. Every organ is going to have thresholds associated with it, and once those thresholds are exceeded, that's when the manifestation of some of the effects can take place. So that's really important once we think about what's going on in radiation therapy, where we're having very controlled plans and very thought out approaches to make sure that we lessen some of those deterministic effects or minimize them as much as we can in the planning process. Stochastic effects are those effects that are just truly random. So all dose carries some risk, but the risk, of course, is increased with increased dose. But it's just not quite as simple as that, in that there are several factors that have to be considered. Of course, the age of that individual is of utmost importance. So pediatric patients, of course, are more at risk than adult patients, largely just because of their inherent radiosensitivity, their rapid dividing of cells. And they're just a little bit more immature. They have their whole lives ahead of them, so the chances and probabilities of inducing some type of cancer can be greater. But different studies have demonstrated different things, and if you're curious about some of those radiation-based studies, I would be happy to share some different studies for you to consider. And when you think and you look at about the pediatric population, about what we can potentially induce, and it's not just peds, and it's adults as well. So I think safe practices need to continue to be applied, but it's about lots of factors: the total dose that they receive, the size of the fields, the location of that exposure also determines radiosensitivities. So are we exposing something that's very radiosensitive, or are we not? So lots of things to consider, but when we think, of course, in total volume, of course, 100 chest x-rays are going to put the individual more at risk than one x-ray, but that's risk alone. That one x-ray still does carry some risk. So these are all things to think about. So largely we're concerned with stochastic effects, but in radiation therapy, deterministic effects certainly are an important factor as well. So the lull of Burgundy and Trippenot essentially tells us that rapidly dividing cells are most sensitive, and also, the more immature the cell is, or the less specialized that cell is going to be more radiosensitive. Also, the point of that cell's phase also is a point of consideration. So the most sensitive cell phase is actually the M phase. So with the least sensitive phase being the S phase, so the synthesis phase. So if you don't remember the cell cycle, dig back in that. But essentially, the X-rays have more effects on cells that have greater reproductive activities. So we have to consider, different types of tissues in addition. And the ICRP has put out several reports that denote specific tissue weighting factors, and while these are combined to express whole body, it gives you an idea of which areas are of most concern. And it's just funny how the report has changed over a 30-year time period, and how very different it is. So you can see from 1977 to 2007, with also a report in 1990, how things have changed. So when we really break down each individual tissue or organ, you can see, hey, bone marrow itself has remained relatively consistent at a tissue weighting factor of 0.12 throughout all forms of these reports. And then what's really interesting is that breast used to be, one of the highest numbers. So second highest or third highest, second highest really by proportion in 1977, and then decreased in 1990, and then subsequently re-increased in 2007. So a lot of studies have come out, demonstrating how scoliosis procedures really can induce breast cancers for young females that undergo those procedures. So utilizing the PA approach, for example, where it's just exit radiation going through instead of entrance radiation, can be an effective measure. Looking at the lung, it remained consistent. Some structures weren't initially investigated in initial reports, but you can see some inconsistencies here with the bowels. But what's really funny, I guess, is that we think gonads as far as our gonadal protection shielding. It has subsequently decreased each year. So I think a lot of considerations need to be made on shielding breasts for individual exams. So we tend to think, hey, if you can't shield the gonads, don't shield the patient. But I think we should shield the patient. So at all times, I think my recommendation would use a shield when possible, because there are radiosensitive organs in these patients, and it's age, while they're not older individuals, do not have as immature of tissues, or maybe as rapidly dividing of certain cells, but nonetheless they still have radiosensitive structures. So geriatric patients, I think it's still important to continue to shield. So typically you think, hey, if they're not undergoing a menstrual cycle, you may not shield, but really I wouldn't say that that's the case. I would say that shielding is an effective tool regardless of the patient's age. So nice food for thoughts here with the ICRP's reports with tissue weighting factors. Now, of course, there are going to be additional considerations when the patient is indeed pregnant because of the teratogenic effects. So, inducing radiation-based effects to a child that is still in utero is something that needs to be considered. Of course, that first trimester is most dangerous because of a vast amount of organ development is taking place. So, hence, we need to be extra cautious the first trimester, but still, the effects can continue even throughout that fetal development process. So potential effects, growth retardation, congenital malformations, fetal death, decreased IQ are things that can happen. It may be determined that there could be a threshold for malformation. So the textbook does cite 100 milligray as being a threshold. So kind of like a deterministic type of effect. So it's not just like that all or nothing, like that stochastic effect, but there may be a threshold associated with it. So specifically trimesters 2 and 3, there is a potential for cancer induction. So we have to just be really careful, very aware. The 10-day rule, of course, is still in effect. So from point of menstruation, start of menstrual cycle through 10 days is considered or deemed an appropriate exposure period. Some facilities do follow a 28-day rule, so if you haven't had a menstrual cycle in the previous 28 days, then you may be at risk. Pregnancy tests should be undergone in that case. Abdominal pelvic, I would say, a lot of considerations need to be made for that exposures to those particular reasons. Certain studies do differ. I think, of course, err on the side of caution, I think is important. But for the most part, when you think about exposures to the chest or extremities, they largely are probably okay. But, it's just those direct exposures that you need to be most aware of. So, applying as many safe practices as possible, though, is very, very important for an individual that may be pregnant. So now at this point, you should all know Image Gently, very great organization that I've had the privilege to do some work with their Back to Basics CR and DR digital radiography campaign. But they have a lot of valuable information on their website. in regards to specific modalities, so CT, interventional, nuclear medicine-based procedures, so all geared around children, largely just because of what we mentioned before, is just they're more radiosensitive than adults, which does put them at a greater predisposition for thyroid cancers, breast cancers, and leukemias, but really all cancers in general. So we have to just be very aware of those stochastic effects. Sometimes it takes these tumors a long time to manifest, so there's a long latent period, which does make the correlations difficult to be able to say this procedure caused this disease. But what can help is in terms of study design, a retrospective type of design where so the individual has cancer. Now let's track back, and if you have enough study participants, you may be able to determine trends. And so those types of studies are very, very effective. So nonetheless, if you don't utilize ImageGently resources in your workplace, I would distribute those, talk to your managers, see how you can get the dose reporting cards out there, provide some of those patient brochures. Whenever possible, continue to educate our patients. Image Wisely, of course, is another great organization, but does have an adult focus. So it still has some valuable information that can be applied to both populations. Now, the textbook does spend a lot of print talking about specific laws, and since these laws are all European focused and not, what's going on here in the States, we are going to talk substantially about laws in other courses. So IMG 405 quality management, we'll talk about laws, dose limits, quality control specifications, and so just kind of keep that in mind. I wouldn't spend a ton of time, educating yourselves on European laws, though it is quite interesting to see what's going on in Europe in regards to this, and a lot of the efforts that are applied in European countries are extremely progressive. So one thing that I pulled out is in regards to something called best practical means. So level of management that minimizes radiation exposure while considering cost effectiveness of that procedure, technological status, operational safety, and social environmental factors. So the NCRP also has essentially in the ALERA policy, or in the ALERA practice, I should say, or guidelines, that we should be considering the technological state. So, what is our equipment capable of doing? Are we using it in the most effective manner? And that's something that we always have to consider, because we always try to practice safe practices. We try to practice ALERA efforts, but we may not understand or fully understand how our technology can work. What can we do? And those manipulations are very, very important to explore and stay aware of. Now, this just sums up to demonstrate that we have to apply as many safeguards as possible in order to protect our patients and ourselves, so and as well as visitors. We just have to ensure safe ALERA practices. Of course, we do have assigned safe levels, but going back to the idea that no level is safe, that stochastic effects can happen at any point, needs to be considered, but nonetheless, historically speaking, safeguards are in place for a reason. Dose levels are in place for a reason. Studies go into them. They're not just random numbers. So they are designed to protect us. That's why we have to wear dose badges, monitors, OSLs, TLDs, just to make sure that we are not overexposing ourselves and potentially inducing some harmful effects. So overarching goals is that we need to prevent deterministic effects from taking place, and we need to limit all chances of stochastic effects. The ICRP has some nice recommendations in place, and really these are followed throughout Europe, that we need to justify, optimize, and limit. So justification and optimization essentially apply to the patient, and limitations apply to us. So in terms of justification, is the procedure needed? Is the likely benefit going to exceed the likely risk? Is there a chance for misdiagnosis? Is it going to result in failure to start an individual's treatment? So in the ICRP in 1990, they stated that 20% of exams were actually not needed. So it's important in today's times to make sure that we are applying the ACR appropriateness criteria. We're utilizing sonography and MR. We're avoiding repeat projections, repeat procedures, especially those happening in close proximity. And in terms of optimization, you know, so if the exam is justified, now we have to carry it out based on ALERA principles. We have to reduce the number of repeat projections. We have to use dose optimization training techniques. We have to train based on the technological capabilities. In terms of limitations, limit our exposures. Simply practicing time distance shielding will help. Time distance shielding is a little bit better spelled out here. So keeping our exposure time to a minimum, both for our purposes and for our patient purposes, using pulse-based settings on fluoroscopy equipment. Lower times, the better. So, the less we can expose our patient, the better. Time is considered to be the most effective measure at creating a safeguard. So something that we definitely should strive to control, but distance is another consideration. Distance is always going to be based on the inverse square law. So in terms of percentage, we are really increasing our exposures at close distance, and so just a step away can really reduce the exposures. So it says doubling the distance away from the source can reduce our exposures by as much as 25%, or bring it down to a level of 25%. So really, really dramatic decreases can take place. In terms of fluoroscopy with an image intensifier, we want to keep that image intensifier as close to the patient as possible. There are safe distances. So 15 inches for a stationary piece of equipment, so a dedicated room, 12 inches for mobile equipment. So the whole idea is to keep the beam further away from the patient, direct exposure further away from the patient. So whenever we can keep the image intensifier close to our patients, we should. In form of shielding, make sure that we're using it for ourselves and also providing it for our patients, and then we're also collimating effectively. Scatter from a patient is considered the top occupational exposure, so just increasing our distance, utilizing shielding and applying as much time reduction as possible is going to be effective safeguards. So these cardinal principles really should be very common to you and should be widely applied in your facilities. Just some specific tips in regards to safeguards for both patients and staff. Immobilization, of course, is key to reduce the amount of repeats, shorter times. Make sure that we're not using what I call a cookie cutter approach and utilizing the same technique for the same patients. So, and this means, not all, adults are going to use the same technique, and it doesn't mean that all children are going to use the same technique. Typically built into an X-ray control console, for example, there's an adult setting that may have, a very large adult, a normal size adult, and then it may have, a pediatric patient. But not all pediatric patients are the same. We just have to think about the exposure factors that we're actually selecting, being very aware of that. One size does not fit all. But further getting into it, make sure that we're applying as many safe practices as possible while utilizing the technological benefits. For staff, make sure you're wearing effective gonadal protection, GP. We say it's lead equivalent. It really probably doesn't have lead in it anymore, but 0.5 millimeters of lead equivalent should be is according to the NCRP is the recommended thickness. But in circulation, there certainly are 0.25 millimeters, so less lead equivalent. And really, in terms of what that's actually protecting us from is really reduced and dramatically reduced. So even though some leads may be heavier than others, I would err on the side of caution and select the heavier ones. Fetal monitors, of course, if an individual is pregnant, they should have double OSLs, so essentially a collar badge and a pelvic badge. That should be utilized just to make sure that we're not the fetus isn't getting exposed, and we need to make sure that we monitor that on a regular interval, so monthly basis typically for fetal monitors, where Traditional OSLs, it depends on your facility setup. They may be used monthly, but they may be used every 3 months, as far as kind of changing them out. So they do differ based on facilities. Finally, one big push and one big key is that we need to document our patient doses. So we need to document the exposure factors that we're utilizing. We need to make sure that, wherever documentation is possible, that we're providing that in regards to entrance skin exposure, dose area product, dose line product, CTDI volume, SSDE really is the key one in CT rather than CTDI. Volume. So if you don't know about SSDE, I encourage you to look up that information. But diagnostic reference levels are certainly important as well. Just makes you aware of is your facility an outlier or not. Make sure that we're making appropriate adjustments accordingly. So I think the Joint Commission of course is requiring more documentation, but just in terms of safe practices, documentation is imperative. Our patients need to know what they're receiving, and I think in time, these are all going to be embedded in DICOM headers, and they'll be saved with the image information, but it is going to take some time to create national-based standards, and dose-based databases would be another effective mechanism to make sure that we're controlling our patients' exposures. And while some exams have to be done, other exams do not have to be done. So it's just it is that ultimate balancing act. We always want to err on the side of caution. We want to use these modalities in an effective manner. They're designed to be helpful in the way medicine is being practiced, and so we need to just do the best that we possibly can to say, hey, this procedure is valuable based on this indication. Now what can we do on our side of things? So once it's recommended, we have to do our jobs. So hopefully you all take that very seriously. I like to profess that how serious these types of things are. So I hope you had some nice takeaway points or some nice refreshers at least from this particular lecture. If you have any questions at all, just be sure to let me know.